Hey, this is Jolie. This is our first lecture in our online learning space. So bear with me as I get to work on my Zoom lecture skills. In this lecture, I'm going to be talking about children with special medical conditions because we kind of transitioned into health over the last couple of weeks. We had spent a lot of time with our nutrition. Now we're going to be deep in our health section. Make sure that you look at the changes to the syllabus that I've kind of done because we're having to change our kind of assignments because we need to stay home, we need to self-quarantine, we need to take care of our own health ourselves. So those have kind of changed. You're not going to be doing the health projects anymore, but there's more information on campus for you guys. So we're going to start with the idea of inclusive education, and this is just that children of all abilities are included in learning together in the same classroom. So a lot of this comes out of a federal law that we have called IDEA, which is Individuals with Disabilities Education Improvement Act, which kind of came out of the 1970s and the 1990s when we were including more adults with disabilities in our workplace and in our communities with ramps, with the tactile blocks, which are when you cross a street and you cross over those yellow kind of raised bumps. Those are called tactile bumps, and those are to help people who are blind and have a walker or the sticks to be able to know where to go and where to stand safely to get on and off curbs and cross streets as well. So what it is we always want to view children as competent. We always want to view children as having strengths. So in this type of inclusive education, we understand and we realize that all children have strengths. They might be shown to us in a different way, that some children are going to have differences in their ability, and we want to promote their success by more individualized education. So if a child is on the spectrum, or a child has medical needs, or a child has low cognitive functioning, we still see them as a small child or just a person who is deserving of the same type of education. They're just going to need a little bit more support in order to get there. This is what I kind of came out of before I started teaching at the community college in Cal State. I worked in early childhood education with infants and toddlers, like I've said before, where I kind of traveled to people's homes to help them with their infants and toddlers in their first environment and their most important teacher, which is their family environment. So we have early identification and intervention. So this is what I came out of, is children very, very young in infancy and toddlers being identified as maybe needing extra support in learning, maybe because of their health conditions. So children's development, we follow certain milestones. We have certain ways of learning and being, and we should probably hit those in certain times. And we talked about this earlier in the class. Some children are going to need extra support in hitting those milestones, and some children, because of their health conditions, are going to need different places to learn, like in hospitals or at home from teachers. If they're very sick, sometimes they have to stay at home and be taught at home from nurses or people specifically trained as teachers and also aware of health conditions. Some children have we also need to make sure that we get children into the special situations that they need. So they might just need early intervention because of a special need, or they might need special health care as well. So they need people who are maybe trained in tracheotomies, which are the cuts in your hole so that you can breathe and you have kind of an airway right here. First time I worked with a child with that, I was very nervous, but through training through the county and through a nurse's kind of training group, I got that special healthcare training that I needed so I could work well with children like that. Or if they have a G-tube, which is a kind of tube into their stomach or their intestines so that they can eat that way because they can't eat through their mouth. With that kind of training, I was able to address those kind of special healthcare needs and also work with the parents on educating the child. We're going to start with allergies because this is one of the biggest health conditions that we have. So 10% of children who experience respiratory allergies are non-white Hispanic. 11% are Black, 8% are Hispanic, and 17% are kind of mixed race. So it's interesting to kind of see how our allergy rates kind of change for children of color. Children living in the South are more likely to have respiratory allergies, and I'm going to play a little video about allergies and allergens and a lot of the plants and species that we have in the southeastern part of the United States, are very allergy producing from the trees and the pollen. And so children are more likely to have respiratory allergies in those parts of the country. A lot of times people would come out to California and the West because sometimes we have less pollen. We still have pollen and allergens for sure, because I get a little of it this time of year, but we might have less than in the South. Boys experience a higher rate of allergies than girls, and they're still exploring the reasons kind of behind that. And children who have poor or very fair health are 3 times more likely to develop respiratory allergies. So I have asthma, and I also have a certain amount of allergies as well, and there seems to be kind of a comorbidity or kind of a link or connection between those two. If you have either of those, you might have one or the other, and they seem to go quite common. And so that might be an example of somebody who has kind of poor to fair health because of their asthma. They're also more likely to develop those respiratory allergies. Children's allergies are not hereditary, so you don't get this from your parent. You typically don't outgrow them, although you can have various forms of treatment and you can live in different places of the world where it might become more manageable. They're typically classified according to the allergen or substance that triggers a reaction. So I used to work, when I would do early intervention, I would always drive to this one neighborhood in Escondido, an older neighborhood, and they had these trees. And I would be feeling fine, and I would get out of the car and I would literally sneeze. Like they were some kind of flowering tree that doesn't grow a lot in other parts of North County. And it would literally trigger a reaction as soon as I got out of the car. And I had to like finally tell the family, they're like, "You're always blowing your nose." And I'm like, "I'm not sick. I promise you I was feeling great until I got out." And then they were like, "Oh, those trees." And then, yeah, like I have a grandma or a family member who's struggling with that as well. It cannot be cured. There is treatment. It reduces your exposure. So a lot of times people will have, like, especially for young children, they'll wash their sheets really, really often if it's like from dust or things within the house. So keeping your sheets really clean, keeping your house really clean, minimizing dust, having hypoallergenic sheets and pillows can control or reduce that exposure to the dust mites and control some of those symptoms like at night. If your child is having a lot of symptoms at night, it's most likely from their bedding, and then we can control those kind of reactive symptoms. There's no treatment for it. It's just kind of managing those symptoms. The most common form of allergic response affects the respiratory system: watery eyes, watery nose, sneezing, sometimes coughing, or shortness of breath as well. We'll get it from pollen, from trees, from mold. That can be quite common as well, growing in a house or outside as well. And that's also in the South, where it can be quite common for people to have allergies. This is a very wet and damp environment. Out here, it's a bit more dry. We don't have as much issues with mold. Dust mites that I were talking about, that can be in your bedding, mattresses, pillows, and making sure that you wash your bedding. And then pet dander, that can be a really common one as well. So a lot of people you might know who might come to your house and immediately start sneezing or know that they have to take an allergy medicine whenever they go to your house. I'm going to share the screen with a video that I cannot link into my video. There we go. So this is a video from Medline Plus, which is part of our government kind of web pages about health and health conditions. And this is a pretty good video that kind of explains the idea of allergies. I thought that was pretty cute. So that's why a lot of times if you have allergies, the doctor will explain to you that you should probably take some kind of histamine or antihistamine in order to kind of manage those cells. They're going to produce the histamine to get it out, but an antihistamine can kind of block some of those responses and make the watery eyes, the nose running less kind of severe. Allergies do affect children, and they affect their behavior and interest in learning for sure, because having chronic itchy eyes, watery nose can be difficult, and that impacts adults. If you know an adult in their life who has allergies, they probably talk about it, they talk about their meds, they might go see even an allergist as well. So it's going to change some of their behavior and interest, and so we definitely want to work with the parents to make sure that if they need antihistamine meds, or if they need special kind of bedding, that it's provided at the school, and that they have the environment at the school that they need that has the right type of bedding, sheets. A lot of times when I had a child who has really severe kind of dust mite allergies, we washed the clothes in the pretend play area much more often than we did in any other classroom. It was every other day in order to keep down on those dust mites. We made sure that we were lucky enough to have a janitor, so making sure that it got cleaned and really cleaned, so things got moved and vacuumed as well, to make sure that we minimized those dust mites at school so that the child didn't have that histamine response. They didn't have all of those kind of symptoms as well. We also have a lot of allergies to food. So we've talked a lot in our class about peanut allergies and the peanut table and things like that. And so most schools either don't want any peanuts, or if you do, you have to sit at a table where you can have peanuts, or the child is isolated with other children who have to sit at a peanut-free table. So why we're so concerned with this is you can have a pretty mild reaction if you eat something that you're allergic to. The most common ones are shellfish. Peanuts or any kind of tree nuts are really common as well. But I've seen children who have allergic reactions to pineapple, cucumbers, so it can be really anything. Another common one is soy, corn, milk. A lot of times children will have an upset stomach. They might have a rash all over their body if it's a mild reaction. A severe reaction would be kind of the start of anaphylaxis. Your airway starts to kind of close up and get swollen, and you will eventually stop breathing, and you can die from the allergic response if you eat a peanut or you're stung by a bee or something that you're really severely allergic to. This will also be taking penicillin or a medicine you're allergic to. That's why children carry EpiPens. That's why it's so important that teachers, caregivers, people at preschools have been trained in how to administer EpiPens. I've had to do it before. It's scary for sure. I don't think you ever kind of get over stabbing a child in the thigh with a really long needle, but I've also seen how important it is and how life-saving it is as well. So children should have an EpiPen at home, in their parents' bag wherever they go. So if they're at Disneyland, they have one there, or at the grocery store, they have one there, because you never know when you might get that exposure to peanuts or shellfish or milk or penicillin or whatever. And you also have one at school as well, and you should make sure that it is has not expired, so it needs to be looked at every once in a while by the people at the school. They need to be trained in how to use it. There are lots of videos online, and if you have a child who needs an EpiPen, you should probably get some kind of training from a medical person at your job as well in order to administer that as well. They are quite expensive, so there are government programs and just programs out there to help families, because that's a lot of EpiPens that you might need to have, especially if a child needs one for school, after school, with their parents, and at home. That's 4 EpiPens. That could be a lot of money. So we need to make sure that we also can support children in getting that as well. All right, asthma, my favorite topic. I am having some issues with my asthma right now, actually. So I literally have my inhaler right next to me. I've been taking it morning and night. It's my steroid inhaler because I've had kind of a rough year with my asthma. I typically just have a rescue inhaler, which is albuterol. So when I start to feel wheezy, short of breath, tight chest, then I'll take my rescue inhaler. But this one is a steroid that I take twice a day as well in order to manage my symptoms as I'm having kind of a hard time. It's very, very common because 1 in 11 children younger than 15 has been diagnosed with asthma. I was diagnosed when I was a year old because I had really, really severe asthma and was hospitalized. Boys and non-Hispanic Black children experience the highest asthma rates. Children who are in poor health or living in poverty are 4 times more likely to get diagnosed with asthma, and it's the 3rd leading cause of childhood hospitalization. So those first 2 are primarily because of environment. So here in San Diego County in South Bay, which would be like Chula Vista National City, we have a lot of rates, and Barrio Logan, we have a lot of rates of asthma and asthma deaths. We have the naval yards, we have shipping, we have a lot of industry down there, a lot of lax environmental regulations over the last kind of 50 to 60 years have increased the amount of smog and air pollution, which then for the children who live in those environments, they are then breathing in really kind of dirty air, let's say. It's not the official term, but that's kind of the idea of a smog-filled, chemical-filled environment in which they go outside and they're probably doing gross motor or running or jumping in air quality like that can lead to asthma as well. So if you live, and I've seen this in other places where I've lived, when I lived in LA, my asthma was not great either because of the kind of bad air quality up in LA. And so in London as well, when I lived there, I could see that as well. There's a lot of smoke and coal and things like that. So the air quality definitely affects it as well. And it's one of the leading causes of childhood hospitalizations. If you were to go to Barrio Logan today, there's beautiful murals down there in Chicano Park, one of our most kind of well-known parks in San Diego County. So if you were to drive down to Barrio Logan, which is kind of, it's basically underneath the Coronado Bridge, they have a mural dedicated to the children who have died from asthma, from living in these kind of neighborhoods near our naval yards and our shipping yards, and breathing the kind of dirtier air of our county. Children and adults, we kind of have the same rates. So this is prevalence rates. So about 8% of the population as children and adults have asthma. More women than men do. And more Black children than white children also have it as well. And this is from 2016. It's also quite hereditary, so I definitely get it from my dad. My dad has asthma, although not as bad as mine. My grandfather had it fairly bad, so I take after him, and my uncle has it as well. Excuse me, I'm drinking my kombucha, so I'm sorry. Yeah, I'm trying to keep my immunity up as we kind of deal with this whole coronavirus, so excuse me. So it's very strong hereditary. It's often seen in children who also have respiratory allergies, like I was talking about in a few slides. It's thought to be related to environmental factors, airborne allergens, secondhand smoke. So when I had really bad allergies, it was the 80s, and the doctor was told my parents who both smoked at the time, you have to stop. So my mom became an outside smoker, and my dad kind of was able to just quit. Chemicals, and they even are talking about early feeding practices, how children are propped up. They're thinking it might have something to do with the tubes and the nasal passages and aspiration as well, though that needs a lot more study. So acute attacks, it becomes very hard for a child to breathe, and typically it could be an airborne allergen. It could be the weather. Mine's definitely exacerbated by cold, dry air. Stress also will make it, and then infection. So if I get bronchitis, I'm basically having asthma attacks many times a day. So typically what happens is your airway within your, kind of the airway right here in this picture down to our lungs, the wall kind of thickens. With mucus, and kind of the muscle contracts as well, so it tightens and it becomes inflamed, and then it's very hard for you to get airflow through it. So your chest will feel very, very tight. You'll have a really hard time breathing as well. So what we want to do is prevent acute attacks, control exposure, and relieve the symptoms as well. So typically what happens is preventing acute attacks, you'll take some kind of steroid if you're having a hard time with it. So you'll have a daily steroid. You can either take it by mouth, like a prednisone that you take by swallowing, or mashed up. My parents used to put my steroid in applesauce, and now I don't really like applesauce because every morning I had to have applesauce with this kind of bitter medicine in it. Controlling your exposure. So if it's, if there's a fire, I don't go outside because of the environmental concerns. Making sure that I stay warm. if I go outside and it's really cold and dry and I don't exercise outside. And then relieving symptoms, which can be like when you have an acute attack, you have to take a rescue inhaler that looks similar to this, and you put it in your mouth, and you typically take 2 puffs and you breathe deeply so that it can get into your airways, and it kind of relieves that tightness, and it allows your airway to open back up so you can get that oxygen that you need. What measures must a child take if a child begins to have an asthma attack? They are going to have to assist the child in going ahead and taking their rescue inhaler. They're going to communicate with the parents as well. And if the acute asthma attack does not get better, they'll also have to call the emergency room, and they will have to go in to the hospital in order to have more treatment for it as well. Another one is anemia. So we're hitting all the A's today. We've got allergies, asthma, and anemia. Anemia is a blood disorder that reduces the number and ability of red blood cells to carry oxygen to the blood tissue. And there's actually a lot of different types of anemia. This is the broader term, and then you could have specific types, but it's just generally where you don't have kind of the iron in your blood. And it can lead to fatigue, being tired all of the time. We had a child, I was training in my job to be an early interventionist. And so I was accompanying somebody else on her kind of visits with children. And so like 3 times, like 3 or 4 weeks in a row, this child was asleep. And like mom was like, yeah, he's sleeping all the time. I try to wake him up. Oh, and when he does, he's lethargic and he just lays on. And the teacher finally was like, you need to go to the doctor and you need to tell them all about this. We need to make sure that he's okay. And then we laughed because he was tired, and if we woke him up, he was lethargic, he wasn't going to want to work. And then by the time we came in, like maybe 2 weeks later, mom was like, oh my gosh, he's anemic. Thank you for sending me to the doctor. And then later the teacher told me herself, she was like, I've seen this a couple of times when children start to act like that, typically because you don't have the iron in the blood, which is giving you that kind of energy. So making sure that you eat an iron-rich diet, and a lot of times you might need to take iron supplements as well. You typically can't give blood either, and it might be something that you'll deal with on and off throughout your entire life as well. You can even get blood transfusions sometimes if you're quite anemic in order to get that kind of iron-rich blood into your body and support those kind of body tissues as well. Childhood cancers is actually one of the leading deaths for children by disease. So unfortunately, some of our higher reasons that children die in childhood is car accidents, both as pedestrian and being in the car themselves, violence and homicide. But if we were looking at just disease, one of them is cancers. So only about 1 to 2 children per 10,000 will develop a cancer in a given year. We do see quite a lot of it now that people are more on social media as well. People are kind of trying to bring more awareness and showing and posting their children's journey through cancer, and then some of the children who pass away as well. There is an improved diagnosis and treatment, and then a lot of the children are able to return to school. So one of my kids' friends had brain cancer, and he spent like maybe 2 months at home when he was undergoing like the really serious radiation, but he was able to return as he was doing some of the chemo and things like that. Like he might miss a couple of days. He got support when he was at home. They had his education come to him, but he was able to go through school kind of in the midst of it as well. Diabetes. So typically there's 2 types of diabetes. Type 1 diabetes, which is something that you are typically not born with, but it's typically more hereditary, and it's not reversible as well. And then we have type 2 diabetes that we typically get older. It's kind of an older onset diabetes, and this has a lot to do with our diet and exercise. And this is more about managing your own personal insulin levels. I had gestational diabetes with my twin pregnancy, which is really common. And I didn't have to do insulin or anything like that. I just basically could eat no carbs. Like if I wanted a piece of pizza, I could have a whole wheat pizza crust, but I had to cut the crust off and just have like the piece. And I have to have a lot of vegetables and protein on it, and that was all I could have. So I could have like a tiny little pizza. So I couldn't I just lived without carbs, but I was able to keep my insulin levels really under control. Children like this, it's a way of keeping their blood sugars under control, but they are going to most likely need insulin that they've either administered to themselves or that they have a pump that kind of administers for them, and they oversee the pump. So it's quite common though, 200,000 children under the age of 18. Type 2 is was rarely diagnosed until recently, but because of our obesity rates, about more children are getting diagnosed with this type 2 diabetes. It used to be something in older adults, middle-aged and above, but we're seeing it at a much younger age, typically because of our kind of standard American diet, very heavy on processed foods, very heavy on fat and sugars, specifically sugars, which can kind of make our pancreas shoot out more insulin, which can lead to type 2 diabetes. So 1 in every 3 US children are overweight and obese, and that can lead to it as well, although that's not the only reasons. Native American, African American, Mexican American, Pacific Islander youth are at a highest risk for developing diabetes. There's some theories that because these cultures have moved away from their more traditional indigenous diets and into a more, once again, standard American diet that's highly processed and high in fat, calories, and sugar, that they are now seeing more diabetes. So previously, Native American, Mexican American, and Pacific Islander kind of indigenous foods would have been high in the local foods that you could grow, vegetables and corn and things like that, and less on the processed foods. And so people are theorizing that as we've moved into this new diet, these cultures are being particularly affected. It could also be because of socioeconomic status and the foods that are available as well. So diabetes, it's really important that you get early diagnosis. So when you're having issues with your blood sugar, you're going to have some symptoms. You're going to be tired. Your feet might hurt. You might need to pee a lot, and that you get that treatment as soon as you kind of are starting to feel those symptoms, because you don't want long-term health complications. Because if a child or an adult has diabetes and it's either not controlled or not known of, you can have some serious side effects, especially if it's a long time without treatment. You can actually go blind, and you might have to have your feet or legs amputated as well, because you're not getting that kind of blood flow to your eyes or to your feet because your body is having to produce so much insulin as well. Weight management is really important, and your diet and intake as well. So making sure that you're not eating a lot of carbs and sugars, and then making sure that you engage in physical activity as well at certain times in order to kind of minimize those ups and downs from kind of that sugar and insulin as well. Lead poisoning is also a very common health condition. So Black children are more likely than other children to have elevated blood levels. And then children 2 to 4 years of age are at the greatest risk for developing lead poisoning as well. And typically lead poisoning is from kind of lead paint or environmental sources, and that's why 2 to 4 years of age are the greatest risk. Is playing outside, maybe playing in dirt in a house that used lead paint because it's an old Victorian house. Prior to the 1970s, all of our paint was lead. That's just how we made it. We didn't know about this, and our pipes might have been made out of lead or might leach lead because of the metals. And so those children are going to be at the greatest risk. Black children as well, mostly again because of socioeconomic status, the houses that they live in, and then one of the big issues in Flint, Michigan, where we're having those water issues, is lead poisoning because of older infrastructure and kind of an ignoring of those types of situations in the last couple of years. So the issue with lead poisoning is that it can actually lead to cognitive decline. So the lead can kind of build up in your body, and it can such that it can actually affect your brain development and your neural development. That's why most pediatricians just have a standard practice of, especially in 2 to 4 years old, testing for lead poisoning, because you're putting things in your mouth, you're playing outside, you're touching, you're actively exploring like you should. But if that also includes lead from your environment, that can be a really big deal as well. I still ask for lead poisoning treatment, or not treatment, tests for my older children as well, because they are cared for at my parents' house, and my parents' house is from the 1940s, and it really hasn't been redone. And so there's lead paint and things like that, and I just want to, better safe than sorry. It's a finger prick on your finger, and then it just kind of tells quickly what the lead rates are. So I just ask for it because I think it's easy, and I'd like to know if there were ever any issues as well. So it has been decreasing because now we know about sources, and sometimes it can be from importing things, so plates and toys, sometimes from other countries that have different or more lax regulations about them could have had lead, but we've gotten better about identifying and eliminating that in the things that we buy. And we actually used to send out little lead tests. I mean, you can still buy them at Home Depot. You rub them on something like a plate, and you can see if there was lead in that plate where they made it. If you have more of that lead in your blood when they test you, once again, like I said, it can lead to behavior problems and a lowered IQ as well. So seizures, I have a lot of experience with this because I had a child when I worked for the military who had really intense seizures. So she had the larger types of seizures where she would fall on the ground, like kind of the traditional or stereotypical Hollywood view of a seizure, where she would fall and she would be convulsing and things like that, and she would wake up and she wouldn't have remembered it. And then she had the smaller types of kind of absent seizures where she would just be like, and she would just kind of not be there. And we could go like this and wave our hand, hey, hey, and she wouldn't respond to us. So about 2 million people in the United States have it, so it's about 1 in 100, so it's more prevalent than our childhood cancers. And about 300,000 are children under the age of 14 years old. This can be because of fetal alcohol syndrome. So if your mother drank when she was pregnant with you, or Down syndrome, cerebral palsy, and some heart kind of conditions as well, you might have a higher incidence of having seizures as well. So most seizures last less than 2 minutes. And these are the large ones and the small ones as well. So you should call immediately for emergency medical assistance if the seizure lasts longer than 5 minutes. If the child has difficulty breathing or no known history, so you didn't know that they had a seizure ever before, call immediately. If they seem to be having difficulty breathing, or if that's the child's medical plan from their provider. So if they are saying that even a 30-second seizure, they need to go into the emergency care, maybe because of Down syndrome, because of a heart condition, something like that. If that's just the plan, then you follow that as well. The child that I had, if she had an absence seizure, we would call her parents right away and we would get feedback from them. They would typically on their lunch break come out, check her out, see how it was going. If she had a large one, we actually just always called for the paramedics. And then it was their decision along with the parents who needed to come to the center right away to make the decision if she should be transported or not. We kind of did that because she had quite severe seizures. They happened quite a lot, and then because of her medication, she was really little. She was 1.5 when she started having it. So 1.5-year-olds and children in general grow a lot, and so adjusting her meds was really difficult. Sometimes it would just knock her out and she would sleep all day and we just wake her up to feed her. Other times she would just like never sleep and just be kind of haywire. So it was a process, and I got really close to the family because I was kind of the point person for dealing with all of this. And the first one was terrifying. I actually sent her teacher with her in the ambulance to the Naval Hospital because this was on base, because she was so scared, the little girl, and we were so scared. I cried. Somebody was, doing the rosary. It was such a scary, scary seizure. She had another scary one a couple of years later after that because she fell in the bathroom and hit her head. And so that one was really scary. Typically what you do though is you observe the child really closely for their breathing, and if you have any concerns about their breathing, don't play it safe, just call for the ambulance. So if you think that their breathing in any way is compromised at all, just make that call. Better safe than sorry, and then roll them to a recovery position when the seizure ends. So when they're having the seizure and they collapse to the ground, you kind of want to grab them if you can so they don't hit their heads, and you want to make sure they're in a large area where nothing is around them. So nothing that as they're convulsing, they could hit their head on, that people aren't near them, that they're not going to get into anything. You see a lot, or you hear a lot of like old wives' tale, roll them up into a rug. I've heard that before. Hold them, push them onto the side, restrain them. You just need to let the convulsion go. You need to let the seizure go, and then roll them onto their side when the seizure ends so that if they vomit, the vomit comes out. If they need to, if they're foaming at the mouth, that can come out. And that kind of recovery position on your side helps with your breathing as well. So that is it. This is a ton of information about health conditions but I thought this is a good one to start on. It's shorter than our other ones, so this is a shorter kind of video for you guys. And from here, we are going to meet online, and we're changing some of our assignments because we are online learning together. Thank you guys for being so patient, and I hope you enjoyed our first online lecture. I'll see you guys online.